Hello, everybody. Today I'm here to present a case to exemplify to you guys the importance and really the reason why we use and apply in my office the Professor Slavicsek concept, VIESID sequence of approach to diagnose and treatment plan our cases, especially those who look for us with certain TMD, okay? This way, I can tell you a little bit about this particular patient. I will not going to show the patient face for obvious reasons, but I will talk and show you my approach to this case and hope makes sense. So if you have any question about this case specifically, you can write me. If not, if you really like this approach, join my courses or our courses in Vietnam, especially now starting in Hanoi in November, coming November the 9th, okay? So let's talk about this particular patient that I am presenting here on my screen. If you see here, the patient looks like nice occlusion. And here comes the point. When we see a very crooked teeth, when you see a very bad smile, bad occlusion, evident bad occlusion, it's easier to do anything because I can see the teeth are not aligned. But this particular patient already received orthodontics before from another professional. And she came to me with a click joint on her right side and a lot of pain. The patient was under severe muscle pain, click in the joint, and she came with a lot of complaints, posture, difficult to sleep. She was taking several medicines for painkillers, and she came to me to try to find a solution for her troubles. So if you look in this particular picture, you can start to see here some abstractions, both sides, but especially here on the left, almost exposing here the bifurcation. It's almost exposing the bifurcation this side here. So the gingival resection here, upper and lower, is more severe on the left than the right side. But if you look, the midline is matching. So it seems there is no really a big problem on the mandibular position. But if you give a close look here, on her right side, we see this ossification here. This ossification gives us the suspect that this area is under overload. And the bone formation in that area is a reaction of the system for this overloading. In certain cases, we can have also bone loss, similar to what we see here on her left. But in this particular case, the reaction of the system was to create bone to protect. So to react to the trauma in that occlusion, in the functional occlusion. Because if we see this picture, this is static. I need to understand the patient in motion, in life. Patient is alive. Patient is not a picture. And now if we go to look to her right side, okay, I see a class 1. The occlusion here is 2 to 1, but look at this canine, very inclined, very inclined and very deep canine. This deep canine impede the mandible to make side movement. So during the lateral shifting of the mandible, The mandible will make a lateral protrusion, okay? During the lateral protrusion of the mandible, the patient must open the bite because the so sharp canine like this impede a normal movement of the mandible. So this condition makes the patient to open the bite to make a lateral protrusion. So at the very end, the system will not gonna make this movement because this is exhaustive. So the patient will, the brain of the patient will give an information to the system to say, don't go to the right. But when the patient goes sleep and brocks, now the things change because we use another brain. We have the same muscle system, but two bosses. One boss when we wake up, another boss when we are sleeping. When we are sleeping, this other boss tells you, okay, now Brock's there. Okay, so during the day, there's an avoidance. And during the night, no. So the patient will severe Brock's in this area here and cause this bone formation over time, okay? The other side, I don't have that sharp canine, and this canine is a little bit more uprighted. So it means that the patient is easier to move to the left, but incisors, as you can see here, very retroinclined. You can see some lines of fracture in all the anterior teeth. So what is the significance of this? The patient is not easy to move to the side and also not forward because the incisors are too deep and too retroinclined. So this way, the system, when the patient goes Brock's, is a very short movement, touching a lot the molars, exhaust the molars. In certain cases, it will exhaust the canines as well because the system must jump on top of the canine. But in her particular case, this is not happening because I don't see the wearing on the tip of the canine. But I can see abfractions, bone loss, and the other side, this exostosis here. So the system is overloaded. Looking from the top, I can see big restorations on the posterior teeth. And why this is happening, especially on the patient left side, in where the abfraction is bigger. So it means the patient Brock's severely on the left side. And why? Because the big canine who's blocking the movement is on the right. So here the patient will destroy with this, as you can see here. And that's why she has big restoration. It's not because she doesn't like to brush. This is trauma. And the patient goes to the doctor, restore once, drop it, twice, drop it, 3 times, drop it. Later on, become a crown. After that, endodontics. After that, fracture. After that, implant, and so on. That's the sequence, because the D-bite blocking the movement. And look at from inside in the lower arch, this exostosis, the torus. So we have here tori, okay? And again, the left side, bigger restorations. Also on the lower jaw. So the system is overloaded. So when you receive an adult patient, these details, we need to pay attention. This is function. Okay, I'm looking to a simple picture. I'm not evaluate this case under the functional situation. There are many ways to do it. When we look to the panoramic X-ray, we can clearly see here the restorations and the bone loss. Endodontics. endodontics on the left. And why this is happening? Because of the big canine on the right side. Because the big canine impedes the mandible move to the right and the patient starts to move to the left and superbrooks the left side. Vertical bone loss all around because the system is very locked and the patient cannot move. And I can see in panoramic some differences in condyle shape, but this is not the ideal X-ray to evaluate condyles, but I can start to suspect a problem and I can ask for CBCT, for example. Here, the frontal X-ray can easily show us that she has also some shorter dimensions on the right side than the left side. And you can see the mastoid process is totally different. This is much higher than this one. So functionally speaking, she's very asymmetric because mastoid process only grows under demand of the muscle input. So if this mastoid is bigger than that, certainly I can see asymmetric function, okay? And also I can see the mandible is not to the right, but this vertical dimension shorter than this one. Okay, I have a symmetry in the mandible in a vertical sense, but not in rotation. This is why I didn't see the shift on the midline on the first picture. I need to take care of that. And you can see here the two borders as we observed on the frontal X-ray. So those two borders is not a bad position of the head during the X-ray shot. What I can see here is that those borders are not matching very well, and you can see two heights on these. This is what you see like a mess. I cannot see clearly the teeth because this side is higher than the other. So this is a really vertical problem. So little by little, we start to understand the patient. We start to see the patient problem. If we now go to the patient condylography, I can see here that she has arthrotic movements and a little bit of changing characteristic on the left. So this way, in protrusion, she has an arthrotic pathway and a little bit short movement on the left. When she goes for the mediotrusion, I don't see bad thing. A little bit changing characteristic on the left as well. So in terms of function on condylography, I will go here. The system on Slavicek concept after I do condylography tells me how should I mount the articulator according to the curves and the function of the joint. So how this articulator will be mounted. During protrusion, the condyle makes a movement on top of the glenoid in eminence, okay? This movement is a functional movement. There's not really to do with the anatomic surface. Of course, the anatomic surface plays a role here, but there's a set of things. We don't have only the bone inside the joint, okay? We have many other things like the cartilage layer or the disc and the condyle layer and the muscles and the ligaments and all these things they are responsible to make the movement. And so this movement happens in a pathway, specifically pathway, and the computer can calculate this angulation. For example, gives me the sagittal condylar curves of 39 on the left and 40 on the right, calculated for 3 millimeters of protrusion. Okay, if I want to move the mandible 3 millimeters forward or within 3 millimeters, any sagittal movement that I want to do, until 3 millimeters. This is the mounting that I have to do. And this left side gives me an insert to recreate or to copy what's going on inside the joint. On the left, it gives me this blue one, which is arthrotic. It's like a straight movement. On the right joint, I don't have that curve, but I have here certain posterior movement being reproduced on that insert, which is the black one. And Bennett movement, 10 degrees here, 1 degree here. If this was a case to build up a crown or build up a full mouth rehabilitation, I should also use those disocclusion tables. Okay, blue, blue, and green for the anterior teeth. If I have to use the patient the way she is at the beginning of the treatment. Okay, I understand how is the patient here. Based on the condylographic curves, I can now see if she has a click, how many millimeters this click happened, how is the quantity of the curve, the quality of the curve, how this movement is happening, and at the end, the software gives me a mounting of the patient situation to copy exactly what is happening in her joints. So I am individualizing the treatment. I am customizing the treatment for this specific patient. So this is not an average or mean numbers. This is exactly the way she is. So after that, I am able now to mount the case on the articulator. And we did. We mount the case on the articulator and we start to do orthodontic treatment. So I will not gonna use the anterior teeth guidance because I will change with my orthodontics. So this way, when we mount the case, I will start working with the upper jaw because I need to open the guidances. I cannot keep canines blocked like that. I can start with a simple straight wire in the very beginning, but this is not a case for straight wire. Full treatment straight wire, I mean. So we will align, remove this interference here. After that, we move to this step number 2, which is mount the overlay guidance using what? What the condylographic curves told me to do. Now I can mount her case on the articulator. Okay? Place the teeth and the jaw in a certain position to avoid that changing characteristic I told you, to allow her freedom to increase the movement, free the mandible to do all the movements that necessary to stay good, no pain, no click, no joint pain, no cervical pain, no headaches, no nothing. Okay? Now, and I am also able to mount the lower brackets because I couldn't. So this is the big difference to place here simple turbos. If I put a simple turbo here, I don't know where I will put the joint. Where is the condyle when I add composite like in the mouse? I have no idea. And this is a symptomatic patient. I could never do anything directly in the mouse, a bi-turbo, for example. This case desired a precise crown creation, precise to go, precise temporary overlay. It's totally different than just put any composite anyway. I am super risky if I do in a case like this, any composite anyway. I can compress more the joint, I can cause more problem. So now the case is ready to mount. And sometimes the people say, oh, the patient will suffer, this is very uncomfortable. No, the patient feels very good because she doesn't have any more pain. This is a temporary moment, very temporary. If we jump in time here, the patient can place elastics to help to join the teeth. And the vertical elastics in the posterior area is not a problem anymore because we have the overlays holding the condyle vertical. So this is just a dental movement. I have no chance for compression on the joint. So moving forward, the case is moving super quick. With us now, we section the wires. This is a moment to break the wires in piece. I cannot finish this case with a straight wire. And why not? Because I need to make interpospation totally different. And I need to give the guidances and adjust the canines customized for her situation function. I cannot trust only the bracket. The bracket itself doesn't give me the appropriate guidance that I desire to customize for her function. And going to the end, we remove the brackets with this situation with a very open guidances, all posterior teeth with open guidances. We maintain in the very beginning, after the removal, certain composites to help her to guide and stay in that position. Later on, we will remove, okay? So now she has a completely open function. There's no more blockage on the anterior, no more blocked canine, no more blocked canine, all positive torque posterior, give the patient freedom to move forward and side to side. From the side, look at that canine was so sharp and so big and very tipped. Now the canine is uprighted with ideal torquing, giving patient freedom to do not have interferences anymore. The other side, same situation, freedom for the patient to move. There is no negative torque, on the posterior. Give the patient freedom to move, and you can see even the color of the gingiva at this moment is really much better than in the beginning. And the case is very, very short. I can treat a case like this if I use this concept in less than 2 years. Okay, less than 2 years, the case is ready. So now, this is what we can get from VIESID concept. But to get results similar to this, where the patient finished with no pain, no more clicks, and the patient feels very comfortable. Of course, after we can perform here cosmetic, bleaching, some composites to close some diastemas. I prefer to add composite than try to retract. If I try to retract, I can cause interference and block the mandible again. So now, after that, I can tell you how can we do it. How a doctor can enter to this kind of way of treatment. The first step is join the VIESID-based curriculum. The VIESID-based curriculum will teach you muscle palpation, will teach you how to mount the cases on the articulator in a simple way using a regular face bow. And after that, you will learn condylography, how to do, how to perform, understand the importance of the hinge axis precise mounting, and we can compare the precise mounting with arbitrary mounting with using anatomic face bow. This way, you guys can understand, interpret the condylographic curves. You will also do cephalometrics to understand here and there how can we do and perform a visual treatment objective, for example. Understand MRIs to see where's the disc, how is that position of the disc. The importance of CBCTs in the treatment, and how should be the occlusion to stabilize and finish ideally cases like that. So at the end, the patient will finish with completely comfort, and muscle palpation must be performed during the treatment several times until I see that the patient finished nice like this. I think everybody could take advantage of this case presentation. Simple, but important. Why important? Because the case looks easy, but the case is not easy because the patient didn't come to me because her smile was pretty. She didn't come to me to say, oh doctor, I want to have a better smile. No, the smile was already so good. She came because she has a pain and also problems in the joint and pain in her neck and shoulder and so on. So now the case becomes complicated. If you don't have this sequence of diagnosis and the concept to reposition the mandible in a specific position during the treatment, you cannot treat cases like this. So join us in November the 9th, Module A of group number 2 in Hanoi. So you can really take advantage of this concept to treat any case in your office, especially the TMB cases. See you with me in a couple months.